Yeah, I'd like to welcome you this morning to our quarterly lecture series. One, thank you for accepting our invitation. Two, thank you for showing up. For some of us in North America, I recognize it's really early. For those of you in Nigeria and probably the UK, I know you've started your day, and I hope you're having a productive day. Before I get to our speaker and our topic for today, I'd just like to give you a brief overview on Health for Nigeria. So Health for Nigeria is a nonprofit organization that was founded in 2019. The mission for Health for Nigeria envisions a Nigeria where every Nigerian has access to quality and affordable primary care, regardless of age, gender, socioeconomic status, or any other demographic factors. So we do several things in Health for Nigeria. Originally, that vision was supposed to partner with the government, to provide access to healthcare. And unfortunately, that partnership hasn't really worked out. But Health for Nigeria since has provided access to healthcare in rural areas in Nigeria. It's provided health education and awareness, just like this program we're having today. We're working on a healthcare leadership and development program, and we have several partnerships with organizations that provide either healthcare or education to Nigerians. Our flagship program, which we're really proud of, is called the Nurses School Program. It was established in 2020 um, with our first program. This program aims to fill the healthcare gaps in rural public schools and communities around the country. We achieve this by setting up sick bays or clinics in rural basic schools, and we deploy registered nurses to these schools in underserved communities. Essentially, we partner with rural public schools, and if they can give us a space, we renovate the space, we tile the floors, fix the roofs, put in doors and windows. We put in medical equipment. We hire registered nurses, and those nurses take care of the children in the school and that local community. In lots of these local communities, that nurse is the only healthcare professional. We started in 2020, and today we're proud to say we have 12 clinics across Nigeria. So the objectives of the Nurses School Program are basic first aid provision at the school sick bay, healthcare education and promotion via the school health club. We started out with COVID-19 education and resilience building, and that's really moved now to health promotion and disease prevention. Our nurses go out to student residents with chronic illnesses, and they educate the families. And most importantly, our nurses go out into the community to perform community engagement screenings for local communities. So the impact of our work so far is we've established 12 clinics across 6 states. We've treated over 25,000 students and over 1,000 staff members, all for free. We've screened and seen over 1,000 members of the local community. So we're really, really excited about the work we do. And so now to transition to why we're here today, let me quickly introduce our speaker. Our speaker is a multinational, not only academic, but also a clinician. Dr. Adele Adeomi is a graduate of the School of Public Health, University of Witwatersrand, South Africa. He has a background in medicine and surgery and holds a Master of Public Health degree from Obafemi Awolowo University, Ile-Ife, Nigeria. He's a fellow of the West African College of Physicians and a fellow of the National Postgraduate Medical College of Nigeria. He's a researcher and senior lecturer at Obafemi Awolowo University, Ile-Ife, with a special interest in nutritional epidemiology. He's also a public health consultant at Obafemi Awolowo University Teaching Hospital Complex in Ile-Ife, Nigeria, where he runs a weekly nutrition rehabilitation clinic for children. He's currently a visiting scholar at the epidemiology unit of Memorial Sloan Kettering Cancer Center in New York, United States of America. So once again, thank you all for being here this morning. I'll transition over to Dr. Adeomi and just let him tell us just a little more about himself, and he'll jump into his presentation. If you have any questions for us, please type the questions in the chat. And after the presentation, we'll address Dr. Adeomi and give him an opportunity to answer the questions. So once again, thank you. I'd like to acknowledge some of the folks I see here, members of our board of directors, a lot of our collaborators, FGC Doani, I see you folks here in North America. Thank you for joining us. So Dr. Adele Adeomi, the floor is yours, sir.
Thank you for the very generous introduction. I want to welcome everybody. I know there are very senior colleagues here and other colleagues. Yes, I think essentially the introduction is okay. I'm I'm an epidemiologist with a clinical background with interest in nutritional epidemiology. I think that's okay. I don't know, with your permission, can I begin, sir?
Yes, please.
Okay. Sorry, can you see my slides?
Yes, we can see slides.
Okay. So once again, thank you, Professor Akintade.
Thank you, Professor Akintade.
And thank you, everyone.
Thank you, everyone.
I'm Adele Adeomi, like I said earlier, and I will be talking about the burden of malnutrition in Nigeria with public health implications. I will be using a rather small outline so that we don't stay here for too long. I'll be introducing the concept, talking about malnutrition, the definition, the forms and indicators. I will give a very brief highlight of the global epidemiology and talk about the double burden of malnutrition, its burden and distribution and trends in Nigeria. Then the determinants of malnutrition in Nigeria, some implications, and some very practical recommendations that I think will be appropriate to this audience. So I usually like to start my discourse on malnutrition with this picture. It used to be very popular then, but it's a little dated now. It first surfaced in 1993, and then it was captioned, "A little girl weakened from hunger collapsed recently along the trail to a feeding center in Ayod. Nearby, a vulture waited." So the background story is, this was at the time in Sudan when there was a serious famine, and multinationals had set up some feeding centers in communities. And this young child was making an attempt to get to the feeding center, but could obviously not make much progress because of the severe hunger. And you can see the vulture waiting, because it was common then that the vultures would wait for children to die and eat the carcass. So when this picture surfaced, as you can imagine, it generated a lot of interest. Well, more about the story is that the child, at the time, the photographer thought the child was a girl, but we later found it was a boy. And the name of the child is Kong Nyong from Sudan. The picture was first published in the New York Times in 1993 and won the Pulitzer Prize for the photograph in 1994. And the photographer, Kevin Carter, became almost like an instant hero. And people were interested in engaging with him around the picture, around the things that he saw. And people were really moved and interested. But something funny happened. Suddenly, the big question came up. And the question was, so what happened to the child? And to the amazement of the watching world, the photographer could not tell what happened to the child. And people wondered, so you mean you took this nice picture and you saw this very horrible thing and you just cleaned up your lens and left? Although there were a lot of explanations and controversies, and the story had it that he actually went back to Sudan to try to find out about the child, which he could not trace the child again. So after 3 months, he committed suicide because of all these the weight of this problem was too heavy for him to carry. A lot of controversies have come up. Some people have said, no, people were not kind to him because they were not permitted to touch the children and many other things. And the father even came out later to try to explain that the boy did not die at the 1993 event, and the boy later died in 2007 for another cause. Well, some people obviously did not believe the story, but the most important part of it was this caption that I want to bring out. The St. Petersburg Times brought out this caption and said, "The man adjusting his lens to take just the right frame of her suffering might just as well be a predator, another vulture on the scene." You will notice the topic initially was malnutrition, the child, and the vulture. Now I've added an S, because according to the postulation of these St. Petersburg Times, there may actually be another vulture that was behind the lens. This is not an attempt to be judgmental of Carter. I think he did a beautiful work to let the world know. I say the story, I think, mostly for myself and for the listeners, that in telling the story of malnutrition, the focus will not be on promoting ourselves or our career or just promoting academic knowledge, but will be to actually help the victims. Because honestly, sometimes it's not just easy to hold the child and hold the camera. You may have to decide which you want to hold. And that is the importance of this introduction. So, malnutrition is from a word, malnutrition. I mean, very literally, that would translate to bad or poor nutrition. But technically, the word is very popular, but it will surprise you that there's not yet a universally acceptable definition. So we describe it. And in simple terms, it talks about when you have too little, that is deficiency, or too much, that is excess, or an imbalance, referring to intake of energy and or nutrients. There are two major forms of malnutrition, which some have described using the term the Great Divide, which is the picture. This picture shows two people in a room, and one appears to be taking so much space, and the other is just struggling to squeeze into a little space. I mean, just a graphic representation of what is really happening. So we have undernutrition and overnutrition, and the forms, the various indicators of undernutrition are underweight, wasting, stunting, thinness, and macronutrient deficiency. We have overnutrition, we have overweight, obesity, which could be general or abdominal. So I want to talk a little more about the indicators. I want to give this background so that the concept, it will give some contextual meaning and understanding when we start talking about the burden. Stunting is also called shortness, and it represents low short height. The height sometimes is referred to as length for young children who cannot stand, but essentially it is measured now. We use the most popular is the WHO reference values, and when it is less than -2, then the child is stunted. The reference values I'm referring to are these. They have them in different forms. This is height for age for boys, and we have for girls too, where we have the reference variables here. So when the child falls below this red line, then the child is stunted. Also, we have it mainly in children 0 to 19, as we have the reference chart for 0 to 4, we have for 5 to 19. There is some relevance of this in women of reproductive age, but it's not very popular. But for women of reproductive age, they are referred to be short when they are less than 145 centimeters. It's an index of chronic undernutrition, which reflects that the child or the person has been exposed to inadequate nutrition over a long period of time. This used to be believed then to be 2 years or more, but recently we are reporting stunting in infants and young children. So it's starting way earlier than it used to be recorded before. Some indicators, another indicator is wasting, which is called acute malnutrition. You might have heard the word like SAM, severe acute malnutrition. It comes from this acute malnutrition. Older texts use the word thinness, but that has been dropped now because there's a new indicator that we use the term for. It represents low weight for height, or some would say, if it is in very young children, they say weight for length, or when there is low mid upper arm circumference. So using the reference charts by the WHO, very similar to what I showed earlier, just that these indicators has changed. Now is weight for length, and we have for boys and for girls. Or we could have for arm circumference for age reference value, also by the WHO, and also when it is less than -2, just very similar when the child drops below this red line here, or this. Older methods then used the mid-upper arm circumference alone, and so you will hear things like severe acute malnutrition or moderate acute malnutrition when the mid-upper circumference drops below some levels. And this also is mainly in children and adolescents, sometimes in pregnant women, because it's very challenging to assess the nutritional status of pregnant women because the weight of the child and a lot of changes in pregnancy makes it difficult to get an accurate assessment. But when the interest is in screening out those that are malnourished, pregnant women, we use the mid-upper arm circumference for values less than 23 centimeters. It indicates acute undernutrition and reflects a recent weight loss or inadequate intake within a short period of time. So another one is underweight, and that represents low weight for age. And that is also using the WHO reference is when we have those values less than -. So just like the other ones for boys and for girls. For this, it's only applicable to children 0 to 10 years because after 10, the effect of puberty makes it difficult for the weight to distinguish between the different statuses. So it's just restricted to children 0 to 10 years. And it's an indicator of both acute and chronic undernutrition, which is the reason why it's quite popular for clinicians for nutritional assessment of children, and possibly because it's quite easier. There are some forms we can do some calculations to get an estimate of the underweight, which makes it more acceptable to clinicians generally. For adults, underweight in adults is measured using the BMI, and any BMI that is less than 18.5 for adults is regarded as underweight. And this reflects both recent loss or a recent or a chronic prolonged inadequate nutrition. So it covers like almost the full spectrum of undernutrition. And now we have thinness. Thinness is when we use BMI for age to define undernutrition. And using the BMI reference charts, just like the others, or only that they are specific for BMI for age for boys and for girls. And it's becoming the more popular indicator, especially in research. And this is for some reasons. One, it uses the BMI, which is the most popular measure of nutritional status. And very importantly, because it helps us to be able to measure both undernutrition and overnutrition on the same scale. All the other indicators I talked about can only measure undernutrition. But this measures both on the same scale. And it also combines all the elements of the other indicators. So for instance, stunting uses height and age, underweight uses weight and age, wasting uses weight and height. But the thinness uses all the indicators, the weight, the age, the height, And it's also an index of acute and chronic undernutrition, so gives a much more complete assessment of the nutritional assessment. And it reflects, like the underweight, both recent and prolonged weight loss or inadequate nutrition. The last indicator for undernutrition is macronutrient deficiency, and this has also been called hidden hunger. This has become even much more popular now. It was not much popular in some older times. I mean, it was not as highlighted, and it reflects inadequate consumption of minerals or vitamins. Some examples of minerals or vitamins, just to refresh our memory, we have vitamins A, B, folate, and we have for minerals, iodine, iron, and zinc. And this is important because it could even occur when enough or even excess energy or micronutrients are consumed. And that is why some diets have been described as they are energy dense, but they are nutrient poor diets, which can make a person even be overweight or obese, but yet would have micronutrient deficiency. And it reflects more of the quality rather than the quantity of the diet that is taken. And it's not restricted to low and middle income countries, unlike all the other indicators of undernutrition I talked about earlier, which are mainly and significantly more in low and middle income countries, but not so with hidden hunger. I mean, the spread, it's global. For the indicators of overnutrition, the earlier indicator is overweight. And sometimes in research, we combine the overweight population and obese and just call it overnutrition or obesity. And it is measured in children using the BMI for age reference charts. There's a difference between the references or the cutoff for under 5 and for those 5 to 19 years. For under 5, the cutoff is greater than 2, as you can see here, for birth to 0 to 5 years for males and females. For those that are 5 to 19 years, the cutoff is greater than 1. As you can see here, this is for 5 to 19 years. All documents are WHO documents. For adults, we use the WHO classification. So for those 25 to 29.9, they are regarded as being overweight. And it's an indicator of prolonged intake of excess energy, nutrients, or sedentary lifestyle, or a combination of all of them. Obesity has 2 forms. We have the general or abdominal, but frequently when people refer to obesity, I mean, we are just talking about the general. The measurement of the general obesity in children, we also use the reference charts. I've shown this earlier, but for under 5 children, it's for when it is greater than 3, for 5 to 19, when it is greater than 2. For adults, is when the BMI is greater than 30, is 30 or greater. For abdominal obesity, which is also called the visceral, the central, or truncal obesity, it's measured using waist circumference, which is the circumference around the waist with the landmark being the umbilicals and the midway between the lower rib and the upper iliac crest. So for women, it is when it is 88 centimeter or more, and for men, it's 102 centimeter or more. So these 2 forms of obesity reflect a more prolonged or a more extreme case of intake of excess energy, nutrients, or with or without sedentary lifestyle. I want to give a very brief highlight of the global epidemiology of undernutrition. Right now, this was according to a document released in 2022 by WHO. There are 9.2% of the world that are undernourished, which translates to 736 million. And 22.5% of these, more than a fifth of these, are in sub-Saharan Africa. For children, using the State of the World Children released by UNICEF in 2023, 7% of under 5 are wasted, 22% are stunted, and 11% of children 5 to 19 have thinness. By now, we know what I mean by thinness. And undernutrition was responsible for 2.5 million under 5 deaths in 2023, which is like half of the global under 5 mortality rate of 30 by 1,000. Amongst adults in 2022, the WHO released this figure of 390 million of adults who were underweight. For overnutrition, the prevalence is rising almost in almost every region and country globally, but the rise is faster in low and middle income countries, with Nigeria inclusive. And the World Health Organization released the document in 2022 showing 5.5% of under 5 children were overweight, 20% of 5 to 19-year-olds are overweight. This is a 250% rise from the 1990 figure of 8%. And currently, 8% of the children are obese, which is a 400% increase from the 2% figure of 1990. And adult overweight also increased by 72% from 25% in 1990 to currently 43%. And the obese population is almost 1 billion people globally, which stands at 16%. Talking about the double burden of malnutrition, what exactly is the double burden of malnutrition? Simply put, we talk about double burden of malnutrition where there is a coexistence of overnutrition and undernutrition. And this could happen at an individual level or household level or population levels. The World Health Organization released this beautiful illustration in 2017 showing the different levels of individual households and population. At individual level, the first frame there is showing a woman that is obese or overweight obese, but at the same time has micronutrient deficiency, which is the reality of some people. The other frame shows a person who, at a point in her life, she was underweight or maybe stunted or any form of undernourishment. But in the course of time, I mean, she had given birth, she had been pregnant, she had given birth, and as an older woman, she's now obese. So as a young woman, she was underweight. As an older woman, she's obese. For the household level, this frame or this picture shows a mother that has micronutrient deficiency, that has anemia to be specific, and a child who is overweight or obese, which is a common, and it doesn't have to be this form. We have a form that could be reversed. It could be the child that is stunted or undernourished and the mother that is overweight, or two children, one is overweight, one is underweight, and different forms of interplay between under and overnutrition within the same household. At the population level, we have a complex mix of different indicators of undernutrition and overnutrition within the same population. So this picture shows children that are thin. As you can see, there is a skeletal frame showing what their weight should have been. They are smaller than what they should be. Those ones are stunted because you can see the frame showing what their usual height should be, but they are short or shorter than what they should be. Then we have those that are overweight, we have those that are anemic, we have those that are just undernourished or thin, and those that have micronutrient deficiency within the same population. So this double burden of malnutrition is a global challenge, but it's more pronounced in the low and middle income countries. And this is because in many of the low and middle income countries, undernutrition is still a big problem. Yet, overweight and obesity is increasing at a faster rate in these countries than even the high-income countries. So we have a situation where there is the big problem of undernutrition that is yet to be over, and the rising prevalence of overweight and obesity, describing the typical double burden of malnutrition. There is a triple burden of malnutrition that has been described, but technically this is also double burden of malnutrition. Its description is mainly to underscore the importance of macronutrient deficiency that was for a long time overlooked when making reference to malnutrition. In Nigeria, to explain the issue of the double burden of malnutrition in Nigeria, I want to use this story of the newspaper boy. There was this boy who, as a young man, sold newspapers to make ends meet. So the people in the neighborhood call him the newspaper boy. It was a small neighborhood. Or his close friends just said news, and they called him News. The boy has since grown to be a successful engineer, works in a reputable company. But when he has a chance to go back to that neighborhood, they still call him the newspaper boy, or his friends still call him News. So similarly, the story of undernutrition in Nigeria or malnutrition in Nigeria started with undernutrition, and then undernutrition was the only nutritional problem or challenge. Not that we did not have some cases of overnutrition even back then, but they were very small or insignificant at the time. I remember there was a personal research I did in 2011, and our aim was to determine the prevalence of obesity and overnutrition in a secondary school. And we found the prevalence of 0, just 2011. So it was not a big challenge then in Nigeria. But now, overnutrition has become a major problem, while the problem of undernutrition is still not over. So we now have typically a technical case of the double burden of malnutrition. But like the newspaper boy story, most people, even including policymakers, are still fixated on the undernutrition only story in Nigeria. And most of the policy documents and government policies in Nigeria are still built around this undernutrition. A popular one is the school feeding program in Nigeria now, where the assumption is that there's undernutrition, so they're just feeding everybody, a blanket intervention, because of the assumption that we have, the only challenge we have is undernutrition. And so, like the newspaper boy story, malnutrition in Nigeria is almost exclusively used to mean undernutrition, even now in the year 2024. So I want to talk a little about this burden of the double burden of malnutrition, but to make it, to organize the thoughts, I put them as undernutrition and overnutrition, just to make it easier to describe. So for undernutrition in Nigeria, according to Global Nutrition Report, 12.6% of Nigerians were reported undernourished in 2018, which is 25 million, translates to 25 million people. Using the Nigerian Demographic and Health Survey of 2018, which the Demographic and Health Survey is probably the most comprehensive data, population-based data in Nigeria. And luckily, it has some nutritional data. Using the nutritional data there for under 5 children, it reports a stunting rate of 36.5% of stunting amongst the under 5 children, translating to 12.7 million under 5 children. 6.9% wasted, 21.7% underweight, 6.3% with thinness, and 41.1% who had moderate or severe anemia. The prevalence of mild anemia is not even included in this. So this is just moderate and severe. And we have 14.3 million under 5 children currently in Nigeria who are anemic. According to the UNICEF data, the State of the World Children in 2023, 35%, which is very similar to the around 36 reported by the NDHS, are wasted. Are stunted, 6% are wasted, 10% of 5 to 19 are living with thinness, and for the adolescent, 10% of them have thinness, according to the UNICEF data. Now, using the NDHS data, that's the Nigerian Demographic and Health Survey, it has data only for women. So talking about women of reproductive age, for those that are adolescents amongst them, 15 to 19, it reported a stunting rate of 9 to 4%, underweight of 4.4%, and anemia 65.4%. While for the older women, the stunting rate was just 1%, underweight was 8.8%, and anemia was 59.1%. I included some personal research experience that I've had in the last 5 years. There was a 2022 study that we did among children 6 to 19 years in 2 states in Nigeria. And we found 10.3% with thinness, 34.9% who were stunted, and 13.5% who were underweight, which compares very closely with what was reported by UNICEF and the NDHS. This other study in 2022 was carried out amongst children living in orphanages, orphan children. So it may explain why the undernutrition rates are very high. And it recorded thinness of 68.1%, 62.3% were stunted, and 55.9% were underweight, and 60.6% were wasted. And there was a 2019 study we carried out amongst in-school adolescents in Ile-Ife, and we had a prevalence for thinness of 12.1%. Talking about the distribution, because the story of undernutrition in Nigeria, it's not complete until you consider the distribution, because there's a lot of inequalities. Starting with the subnational distribution, you can see that the prevalence or the burden of under 5 stunting rates in Nigeria almost divides Nigeria into a very sharp, overburdened north and a less burdened south. In actual terms or actual figures, we have for each of the states, starting from an Anambra that is just around 14% to almost 70% stunting rates in Kebbi State. The total prevalence for the country is 36.5%. And you can see that all the states that are above this national prevalence are northern states, while all the southern states are below the national prevalence. And the northern states that you find below are the Federal Capital Territory and the nearby Nasarawa states, or the ones bordering the southern states. So it's a big divide between the north and south, talking about the stunting rates. And also using the under 5 stunting rates across the sexes, you can see that it's more prominent amongst the males. And the regions, the 2 regions in Nigeria, Northwest and Northeast, account for more than 50% of all the prevalence of under 5 stunting rates in Nigeria, much more than the remaining 4 regions. And you can see that the Northwest, this Northeast, and the North Central, in that order, have the larger burdens, while the South has the lower burdens of stunting rates. Using residents, we see that it's more of a rural problem. And the wealth index. The poorer quintiles, which are just 2 of the quintiles, are more than 50% of all the burden of under 5 stunting in Nigeria. And whereas the richer and middle have much more smaller burdens. So you can see that it's more of a problem of the poor in Nigeria. And the trends, I use these findings from the 1990 to the 2018 data from the Nigerian Demographic and Health Survey. And we can see that it's not really been a consistent drop. It's been a little bump here, but it came up, then down. I think it was from 2013 that we had a consistent drop in the under 5 stunting rates in Nigeria. And to give us more perspective, I tried to give us the percentage decrease from 1990 to 2018. So we have the stunting rate dropping 44%, wasting dropped 36%, and underweight was the highest gainer that dropped 54.5% from 2019 from 1990 to 2018. For overnutrition in Nigeria, some national prevalence rates here, 3% of children under 5, which is about 1 million children, had the overweight and obesity, according to UNICEF. NDHS reports in the same population, in the same age range, 2.7%, which is almost the same thing. UNICEF reported a prevalence of 8% among children aged 5 to 19, and UNICEF also reported 8% amongst adolescents. The NDHS reported a total prevalence of 28.5% for overweight and obese among women 15 to 49 years. There was a beautiful systematic review and meta-analysis that was recently done in Nigeria to help to have a national perspective from what different researchers have done. And the findings were not too different from the findings of the NDHS, although there are like 4 or 5 years between them. But generally the trend is the same, though this is much more higher. The 42.1% he reported here is much higher than the 28.5% reported 2018, which like 4 or 5 years before this. And that translates to like 91 million people. We can see here that the obesity amongst women is 23% compared to 10.9% amongst men. And overweight is common in the two groups with 28.3 and 26.3 amongst women and men respectively. From my own personal research experience, I put some data that I've worked on and some published work in the last 5 years. And a recent work that we published amongst female adolescents reported all prevalence rates here of overweight and obesity together. We reported a 10.2% amongst female adolescents. In 2022, amongst those 6 to 19, we got a prevalence of 10.3. In 2022, also a separate work. This was done amongst in-school adolescents, and we had 12.8%. Amongst university workers, OAU workers specifically, Obafemi Awolowo University workers in 2021, we got a prevalence of 69.7%. In 2020, amongst those 0 to 19, we got 8.9%. And amongst adolescents in 2019, also we had 10.2%. For the distribution of overnutrition, also, if you look at this picture, it almost reflects an inverse picture to the prevalence of the stunting rates, the under 5 stunting rates earlier, where now we have the higher burden in the southern region and the lower burdens in the northern region. And more specifically, we see that Anambra State that had the least stunting rates, interestingly, also has the highest overnutrition rate, with a rate of 54.6, which is, sharply contrasting to 6.9% in Sokoto. And the overall prevalence here too is 28.5%. And we can see that most of the states here above are the southern states and below are the northern states, just almost the other side of the coin for undernutrition. More specifically, comparing the regions, which we can have a picture of it, using the NDHS, we see that the highest prevalence was in the south-south, the lowest was in the northeast. Here also, the highest was in the south-south, using the systematic review and meta-analysis by Chukwu Onye and his colleagues. The highest prevalence was also in the south-south, and the lowest was in the northeast. And we compare the overalls, you can see that highest was south-south in both, followed by southeast in both, southwest in both. The same flow. The only thing is that we have a higher prevalence in 2022, which may be a reflection of the 5 years or the 4 or 5 years the 4 years since 2018 to 2022 when this was done. For the distribution of malnutrition in Nigeria, some other specific context in age, in one of the most graphic representations of inequalities in the distribution of malnutrition in Nigeria, we have a case from the same NDHS data. Female under 5 children, we recorded a prevalence of 2% for overweight and obesity. And in females 15 to 19, there was a prevalence of 10.2%, more than a 500% increase between the different age groups. Amongst the sexes, we see, unlike the undernutrition that was more prevalent amongst males, overnutrition is more prevalent among the females in Nigeria. Using the systematic review that was done. And also we see that it is mainly an urban problem compared to the rural. And the wealth index is another very graphic representation of the inequalities, with the richest households having a prevalence rate almost 50%. That means almost half of adults living in the top quintile of the wealth index in Nigeria are overweight or obese, whereas we have less than 1 out of 10 in the poorest households that are overweight or obese. And for the trends, I use the figures from the Nigerian Demographic and Health Survey. And what the first thing we notice here is that the increase in overnutrition, unlike undernutrition, has been much more consistent. The increase has been much more consistent and has been increasing at a more consistent rate, unlike undernutrition that was up and down until maybe 2013 when we noticed a very sharp decline. And to give us a closer context, I gave some percentage of increase. So we have overweight increased 23%, but obesity increased 71% from 2003 to 2018, just within 15 years. All the previous presentations I've made have just been double burden of malnutrition at population level. I wanted to stick with national prevalences to give us a more holistic picture of Nigeria. But I want to use a case study of our 2021 study here to give us a full spectrum of the existence of the double burden of malnutrition at every level in Nigeria. So the study was the double burden of malnutrition among school-age children and adolescents, and we used 2 states in Nigeria. So what we found was that at individual level, 4% of the respondents who were 6 to 19 years had both overweight, obesity, and stunting at the same time. So we had a case of children who were both overweight and overweight or obese, and stunted at the same time. And for the household level double burden of malnutrition, the one that was most prevalent was that 18.2% households had a mother that was overweight or obese with a stunted child within the same household. And we are not talking about children from different mothers. We are talking about mother-child pairs, biological mothers. So we have almost a fifth of households having a case where we have overweight mothers and stunted children. And the population level was even maybe much more graphic, because we have indicators of overnutrition as overweight and obesity, and indicators of undernutrition, thinness and overweight, almost being the same proportion within the same population that we studied. And this was a population of 1,200 children 6 to 19 years. So that this kind of gives us the picture of the double burden of malnutrition in Nigeria. So what are the determinants? It's actually very difficult because malnutrition is a very complex subject, but our attempt to talk about these, we can understand some factors about undernutrition using the UNICEF framework. It's a 1990 framework, but it's still very relevant now. If you look at it, most of the basic causes listed here, the underlying causes, and even the middle causes are still very prevalent now. And so it should explain why the problem of undernutrition is far from being over. While there has been some traction that has been gained, but there's a lot that still remains undone, because almost every factor that we point out here, the economic factor, it's not, I mean, the war is still very, very much from being over. Political and ideological factors, human, economic, almost all those factors are still a problem today. Hence why undernutrition is still a big problem. Now, this undernutrition is superimposed, if you may allow me to use the word, with an increasing rate of overweight and obesity. And this has been attributed to nutritional transition, which is a shift from the traditional to the westernized dietary pattern and reduced physical activity. Well, I don't want to dwell too much on nutrition transition, but that has been due to a lot of factors. Urbanization, one, and globalization is a major factor. But just to understand that there's been a shift, I mean, in the patterns of diets, and now with more sophisticated equipment and automobiles, we now have more reduced physical activity, which compounds the transition to heavier nutritional statuses. Some proximate factors which we could consider, a number of them have been highlighted in literature. I just want to bring out some. We talk about age, sex, and many other demographic factors. I've highlighted earlier the graphic differences in the age structure. So while we have undernutrition is commoner in the younger people, overnutrition seems to be commoner in the older people. And I've also highlighted the sex differences earlier in adults, where we have females having a prevalence more than 50% and males 37%. The other is socioeconomic status, including education, occupation, income, family size, resting, and many other things. The wealth index is a very helpful indicator, which was mainly made popular by the Nigerian Demographic and Health Survey, which combines a lot of factors, a lot of household possessions and things, to come up with an index of how wealthy a family is. And that would explain why there was a very graphic representation of the inequalities in socioeconomic status, with the prevalence of stunting rates that I showed earlier. And we also have environmental factors. There was a beautiful study that underscored the importance of clean water and sanitation for undernutrition. And we have had a lot of challenges, climate change, to which Nigeria is very much affected to. Diet has been implicated also in some proximate factors, that is both, on the inverse side, that is causing the undernutrition, and the flip side causing overnutrition. There was a study that I worked with a few of some senior colleagues that underscored also the importance of dietary diversity and dietary patterns in the double burden of malnutrition in Nigeria. There are some other contextual issues, the issue of securities, economic challenges, family planning, uptake, immunization, and others. So for the implications of double burden of malnutrition in Nigeria, I want to just talk about three major implications here. There could be more, but just to keep this presentation quite simple and easy to grasp and work with. One is child health and survival, also the rising prevalence of non-communicable diseases, and the double burden on health facilities and resources. So for the child health and survival, there were 852,000 under 5 deaths in Nigeria reported in 2023 by UNICEF, which was the highest number in the world, ahead of India, Pakistan, and DR Congo. Nigeria does not have the highest child mortality rate, but because of the big population of Nigeria and because of the relatively high mortality rate, so we have almost 1 million children who died as under 5 children. And we have the burden of infectious disease is still very high. I try to stick with with national prevalences here, but so that's why I use the malaria indicator survey for 2021 that reported 22% of those of the 6 to 9 to 59 under 5s that tested positive for malaria. But some other studies have reported even much higher prevalence for malaria infection and other infections. Now, it's important, the importance of this implication that have been raised is that malnutrition is responsible for half of the under 5 morbidity and mortality, translating to more than 400,000 deaths in Nigeria alone of under 5 children. You know, some people try to use some graphic examples to make this more understandable. So a coastal bus, a big coastal bus will be able to contain an average of 40 children. So it is like saying that 10,000 of those coastal buses loaded with children like that has an accident and dies every year in Nigeria due to undernutrition, which is a very big loss. So the other implication is the rising prevalence of the non-communicable diseases. The Food and Agriculture Organization released their data on the increased death rates related to overweight and obesity in Nigeria, and reported 79% amongst men and 29% in women. There was a systematic review and meta-analysis on the prevalence of hypertension in Nigeria, and it reported that the burden of hypertension in Nigeria increased from 4.3 million in 1995 to 27.5 million in 2022, with a current prevalence of hypertension, not even mentioning pre-hypertension, of 30.6%, almost a third of all adults in Nigeria having hypertension, which is 66.7 million actual numbers today. Also, the Global Nutrition Report shows that 6.8% and 7.5% of women and men have diabetes mellitus, which a systematic review and meta-analysis on DM in Nigeria also reported a 2.6-fold increase in the prevalence of diabetes mellitus over the 2.5 decades. So now that we have a prevalence of around 6%, a combined prevalence of 6% in Nigeria, translating to 12.5 million in actual numbers. And the challenge on health facilities is now the health facilities or the health system in Nigeria is also already weak and poorly financed. According to a licensed commission on the health systems in Nigeria, led by Abubakar in 2022, Nigeria did not achieve any of the health-related MDGs. Even our progress towards the SDGs is very suspect, and the spending on health is very low, and the primary health, even secondary health level of care, some people have even said it has collapsed. A review in 2017 showed that the primary health care now lacks the capacity to handle essential healthcare services, with many challenges that were listed. The contemporary issue of massive immigration of healthcare workers is another assault on the already weak and poorly financed health system. Recently, the health minister was reported that there are only 55,000 doctors for 218 million Nigerians, with 16,000 doctors departed Nigeria in the last 5 years. For nurses, the picture is even more grave, with 42,000 nurses leaving Nigeria in just the last 3 years, according to the Nurses and Midwives Council of Nigeria. The Medical and Dental Consultants Association of Nigeria recently released a report showing that 5 northern states in Nigeria have less than 300 doctors each in the entire state. And the challenge with this is that there is the additional burden of the increasing non-communicable disease. And the burden of infectious diseases is still very far from being over. So, to begin to round up this discussion, what then are some practical recommendations and way forward? I don't want it to be about some highfalutin recommendations or about government and what government should do or not to do, because this is not essentially a presentation to the government. There's a lot the government needs to do, but I try to tailor this to what any one of us can do and achieve. So I made it quite simple and easy to align with. The first thing here I pointed out is the need to raise awareness about the nutritional state in Nigeria and also nutritional education, which is, what the Health for Nigeria is trying to do, which is highly commendable. We need to use every opportunity that we have to draw attention to the double burden of malnutrition in Nigeria, and not just undernutrition, but especially to draw attention to the rising prevalence of overnutrition in Nigeria, which seems to be presently as if nobody is even talking about it. Because we have some modest gains in the fight against undernutrition. It's very modest. There's a lot that still needs to be done. But the issue is that the fight against overnutrition seems not to even have started at all. And a major driver of under and overnutrition in Nigeria is poor nutritional knowledge. Someone may argue that it is economic, or it is due to wealth or economic status. But I have some research experience and practical experience as a practitioner that, justifies the fact that while wealth index and economic status remain very important factors, poor nutritional knowledge is a very, very big factor, even amongst communities that are considered poor. And 2 important experiences I want to highlight here is my youth service in Sokoto. I served in Sokoto State for my youth service 18 years ago in a village called Kuchi in Kebe local government area. And this experience was probably the the biggest reason why I'm in nutrition epidemiology today. There may be another reason which, well, it's not academic, but the most important academic reason would be that experience. Because when I got there was a big problem with undernutrition. And I'm not talking about the kind of undernutrition that we see in the southern part. When you look at a child and you can almost completely highlight the skeletal structure of the child, that was how bad the nutritional case was. And as a young doctor, it was not long that I discovered that treating infections and treating the conditions they came with was not helping, because I would treat them and they would be back again, because like the complex mechanism of immunity and weight status that may be beyond the scope of this discussion. So I now soon discovered that I needed to do something about the nutritional issue. I spoke with a few of the women and found out very quickly that a major challenge was children were weaned to a predominantly millet meal, millet pap. In the local parlance, it is called kunu, and it is just kunu. It is just this millet pap, like a paste that is served to the children with no form of protein at all. Millet has protein, but very little content of protein. So many of the children came up with a lot of the indicators of undernutrition in very graphic forms. So I discovered in this same community that, of course, is a very poor community, that one of the cheapest commodities in that community was quail eggs, because there were a lot of quails. They were big on quail farming. So quail eggs were almost, they almost cost nothing in that community. The other thing I discovered was that most of them were, most of the women were traders. Their major source of trade was what is called kuli, granite cake. And granite cake is very, very nutritious. Granite in itself is very nutritious. Another thing is that majority of the villagers were fishermen, so fish was very popular. So what I just did was I stopped most of my consultations and changed most of my clinics to nutrition, educational settings. So I'll bring out those cheap sources of protein, and I'll show them how they can dry these sources and grind them and mix them with the pap or the millet pap that they were giving the children, and how every child should have at least a quail egg per day, which was very convenient for them to do. So many of all these things within the context of that community were not really expensive. And I saw almost magical transformations in many of the children just within the 1 year that I was there. The other experience I have is that the nutrition clinic I run weekly, we have the mothers that come to the clinic span all wealth groups. We have had bankers, we have had skilled executives, many who have brought their children because they were undernourished. Because many of them, they may be well educated, but basic things about the nutrition specific to different age groups may be lacking in them. And that is why I personally think that one of the biggest interventions that can be done for anybody interested in moving forward with this case of malnutrition in Nigeria is raising awareness about it and educating as much as possible. I gave you a list of some platforms that can be used for this. The hospital-based platforms. Already we have antenatal clinics in many settings, many communities, where there traditionally is a section for health education, which could be used to give balanced and correct education about the nutrition of children and of adults. Then we have nutrition clinics. Traditionally, most primary health care centers should have a day for their nutrition clinic, although many people are not running this, but this should be revived. And there are some important existing programs like the Baby Friendly Hospital Initiative, which should be revived and sustained within the hospital, that can help to increase awareness and educate people on nutrition. Then we are in an information age, so the media, internet especially, can be used. We have had some people that use the social media to educate people, and we have also had some people use the YouTube, radio, and television. This is very important, not only because of the need to create to give some creative content for nutrition. But it is important because there are a lot of false contents, wrong information that are available on nutrition online. So we need something that is balanced, that can help to address, or if you may, that can help to counter some of these negative narratives about nutrition and health in the new media. Then we have community-based programs that can be used, religious gatherings, community village meetings, landlord association meetings, where we can use to address. And oftentimes when these community-based programs recognize that we are health workers or researchers or scientists, they would gladly share their platform for you to educate them on something related to health. And we can use this to address nutritional related issues. We can also use our professional association meetings. There are quite a number of them. Forgive me, the ones I mentioned may just be the ones that came readily to me, but they are much more than that. So we can use their annual general meetings or other meetings. Then we could use school-based programs. This was something I was pushing for a grant for, to try to train nutritional advocates in secondary schools around Osun State. Yet not successful, but of course, I'm going to try more and more. So we could raise advocates in our higher institutions, in high schools and secondary schools around the countries for nutrition, to raise awareness about it and educate people. The other thing that I think, the other point where many of us can come in as researchers, as scientists, as interest groups, is to have contextually appropriate interventions. This is important because a number of interventions have been done, but many of them are not guided by empirical data. There is a clear distribution pathway for both under and overnutrition in Nigeria, and this must be recognized in all the attempts to intervene. For example, we have seen clearly from what I presented that undernutrition is high in children, overnutrition is high in adolescents and adults. So if the federal government was proposing that they wanted to do this school feeding program for children in primary and secondary schools in Nigeria, well, it may be appropriate for those in the primary schools, but not even everyone in the primary school. May be appropriate for the under 5 in primary school. But adding energy-dense food to the plate of children, where we already are recording 10% of them that are already overnourished, overweight, and obese, will not be contextually appropriate. And the other thing that is done in Nigeria is that we have these states are given, like for instance, the federal government wants to tackle undernutrition. Well, most of the time when Nigeria talks about tackling anything nutrition, it is undernutrition. Like in the story of the newspaper boy, to Nigeria as Nigeria as a whole, talking about the political leaders in Nigeria. The malnutrition in Nigeria is still spelled undernutrition. So when Nigeria says they want to intervene in undernutrition, they give the same resources and the same attention to each of the states. Whereas Anambra as a state and Sokoto as a state are not dealing with the same things. So they cannot have blanket interventions for the two states. So that's why I use the word contextually appropriate intervention. And we should target sustainable, not just snapshot intervention programs. A lot of what we see today are snapshot programs. So an example is an NGO, and we see this, even many of the diaspora people that are really interested in helping, which is not due to any fault of theirs. For many of them, what they see that they can do, what they see people doing, is that they gather these people, and usually they will go to the southern part of the country, or even if it's in the northern part, they go to the urban centers and just gather people and distribute cartons of Indomie and cartons of spaghetti. Those are not sustainable. and those do not really help much. Because, okay, you give them a packet of spaghetti or a packet of Indomie, and they eat that for how long? Maybe even a month. Then what happens after? So I gave some examples here of what I think are sustainable interventions. The list is not exhaustive, of course. We could train and support peer educators or advocates for nutrition in communities, in villages, in schools, in institutions. We could sponsor weekly programs for nutrition education on radio, TV, or even sponsor YouTube channels or social media channels that will talk about a balanced information on nutrition education. And like the Health for Nigeria is doing, establishing primary healthcare centers, especially amongst the people that really need it, the rural communities, where nutritional education services could be offered routinely, which is a very laudable project, which all of us too can key in. And there could be many others that could be suggested. The other helpful recommendation and way forward is for us as health workers, or for all those that are involved in health in one way, whether directly or indirectly, whether as clinicians or as scientists. There is a need to update our nutrition knowledge. It is unfortunate, but many healthcare workers cannot properly, I'm just giving an example, cannot properly assess nutritional status, especially of children. So what we do in most of the health centers, we take the anthropometric measurements, but we don't do any interpretation. I've done this many times. Now I've approached many health workers, nurses, doctors, and for the nurse or for the health worker who has just measured the weight of the child and writes it on the card, then I'll ask the nurse, Matron Ma, so what does this mean? You have just measured the weight. What does it mean? And you find many of them saying, the child is undernourished. I said, based on what? And they don't have any scientific way to assess the nutritional status. So there's a lot of information, even amongst healthcare workers, that are given as forms of nutritional counsel or advice that are very inaccurate. So for health workers, most of the time people cannot differentiate between who is into nutrition or who is not a nutrition practitioner. You are just a health worker and they come to you. And so we need to update our nutrition knowledge. And we need to pay more attention to nutrition in the diagnostic procedures and the management of clinical cases. If a child comes to us and the child is having malaria, the malaria is at best, or the malaria at best may just be a secondary outcome of a primary problem of undernutrition. Or if a person comes to you and the person is hypertensive or diabetic, the diabetes may just at best be a secondary outcome of a primary problem of overnutrition. It will be very erroneous that in making our diagnosis and in drawing our management plans, nothing is mentioned of nutrition, or attention is not paid to nutrition, which is, in fact, may be the primary driver of the symptom or the sign that the patient is manifesting. We should also maximize existing nutritional structures and programs. There are a lot of programs that have been done, albeit it may be focusing more on nutrition, but they are still existing. Many in our ministries of health, many at federal levels and state levels, that as healthcare workers, we must work with these people to maximize. There was a personal experience I had of the ready-to-use therapeutic food. There is this ready-to-use therapy, which was like a magical solution to many children that were having severe undernutrition at a time. And these were produced in form of, I guess a number of people can remember them as plumpy nuts or F100, F75, that was made by many multinationals, the WHO, UNICEF, and the like. And I went for a training then, and they talked about these plumpy nuts. And as at that time, I was working as a resident doctor. No, I was even a consultant in Lautech Teaching Hospital. But at the time, I did not know those plumpy nuts existed. I thought they were just theoretical. But in the training, I was told that there was a lot of there was like much of the plumpy nuts that are wasting in the ministries of health because healthcare workers are not making requests for them, or they are not requesting for them. I was very shocked to hear this. So when I went back to my practice station then, I went to the ministry in Osun State in Abiri, and I asked them that, do you know anything about the ready-to-use therapeutic? They said, oh, yes, we have a store of the therapeutic food. And I said, oh, I need some. They said, oh, that's good. And they were going to give me very willingly, without any stress. Unfortunately, by the time we got there, the batch they had all expired. Now, you may ask the question, why are the ministry staff not taking them around the health centers? Well, like I said, the aim of this presentation is not to lay blames on government or government parastatals. If we continue to do that, as Nigeria will remain at the same place, I think it is time for us to be more proactive. If they will not come to us, let us develop healthy relationships with the units, with corresponding units in the Ministry of Health, so that when any program is available, we can know. Recently, also last year or 2 years ago, I was applying for a consultancy job, and I was shocked to find out that there's been a program, this nutrition education program, many beautifully produced documents, that were produced for nutritional education at the primary healthcare level, existing in the federal ministries, but I had never seen any of these documents before. And they were given out the consultancy to update the information, because there had been 10 years that they had produced the first one. 10 years. Here I was at the time, more than 10 years as a nutritional epidemiologist in Nigeria, and I've never set eyes on those documents. So this recommendation is important, so that we need to maximize the existing structures and programs. We need to familiarize ourselves with what is existing, develop healthy relationships with those at the federal and the state ministry levels, so that we get familiar with these things and be able to use them properly. We should learn also to collaborate with NGOs, religious organizations, and other interested persons organizations. What I discovered in Nigeria is that many people think that people are not interested, but I think it is not correct. Many people are interested, many religious organizations are interested, many even persons, individuals, small-scale businesses are interested. But we need to send the word out. We need to be more proactive, and need to be more believing when it comes from us, the health workers. So I wrote here that the health workers should also stop calling the young man the newspaper boy. We should draw attention to both under and overnutrition, and we should stop presenting the picture that it is only undernutrition that we have in Nigeria. The other area I want us to shine light on is nutritional research. There is a great dearth of nutrition data in Nigeria. An example I gave here is that we just defined nutrition transition, which we said is a major issue driving the dog burden of malnutrition, and as a shift from traditional to the westernized dietary patterns. Therefore, this underscores the need to understand the dietary patterns and monitor dietary patterns of Nigeria. But it will interest you that the first validated food frequency questionnaire, which is an instrument that you need to get the frequency of food consumption so that you're able to develop the dietary patterns. The first one was for adults. There's one that was developed for children and adolescents much earlier. But for adults, was only published in 2023. So there is still a lot that needs to be done. Another major problem is the quality of available research. The available research I've used different. Now I took us through, and it was intentional, the meticulous review of the different indicators because they mean different things and they are speaking to different contexts. But a number of research in Nigeria they have mixed up these values, and so we have conflicting results. There was something I wanted to put up here, but I thought it will not be helpful for the researchers. I don't know, maybe the researchers are even here, so I don't want it to be personal. But there was a particular community where a research was done on the nutritional status of children of the same age group within the same community. By two researchers within the same 5-year bracket. While one reported a value much lower than 5%, another reported a very high value in the same community. And when I checked, what you find out is that they were interpreting the nutritional status using different reference values. So there are recognized reference values which have not been much aligned with in a number of the studies that have been done. And many studies in Nigeria are just scattered, very restricted to small geographical areas, like studies within a little city, very few within states, but most of them are within small communities and cities, and very small sample sizes. And most of the studies are concentrated in the southern and the urban communities. So someone may say that we have the Nigerian Demographic Health Survey, which is probably the most comprehensive nationally representative nutrition data. We have others, we have the multiple indicator cluster survey and the nutrition and health survey, but the NDHS still provides the most comprehensive data. The problem with the NDHS is that we don't have nutritional data for men, and we don't have nutrition data for those that are 6 to 14 years. So we only have for under 5 children and women of reproductive age, 15 to 49 years. And the most current version of NDHS is 5 years old already. So it's already dated. So there is need for more interest in nutrition research for both clinicians and scientists. And for those that may be interested in sponsoring or offering grants for nutrition research or training. I want to add this slide on individual and household level. There is a need for continuous assessment and monitoring of the nutritional status of household members. There is an unpublished manuscript that I'm working on presently here at MSK. And it was interesting that very different from what is observed in high-income countries like in the US, majority of Nigerians don't know their nutrition numbers. So if you ask a Nigerian, so what was your last weight, body mass or weight? When this question was asked in that study, less than 10% actually knew their current weight. But it's very different when in other countries where majority of people will know and will even tell you, this is my current weight, I measured this was the one I measured last year, and things like that. So there's a need to be more interested in our nutritional status, and there should be a high level of intentionality with food and dietary choices. I've worked on a few papers on dietary patterns, maybe 2 now. I'm working on maybe the 3rd one now. And a consistent thing that we find is most of Nigerians, they belong to a group, a dietary pattern that we have called diversified dietary pattern, because there is no intentionality behind this pattern. It's just as if majority of people just eat whatever is available. It's not, we have civilizations where people say, I'm a vegetarian, so this is the kind of food I'll be eating. Some say, I want to be taking Mediterranean diet. Some say, I want to be taking this. But in Nigeria, we find that people just basically eat almost everything that is available. So we need to be more intentional about the diet. And also dietary structure should be based on need and empirical data, not some cultural background. For instance, the size of the meat in the house should not be proportional to the person's age. It should be proportional to the person's need. And attention should be paid to children for protein-rich diets. Adults should be different. You know, the structure of the diet should not be based on, this is what children should eat, or this is what adults should eat. It should address each person's situation. If there's an adult in the house that's already overweight, the structure of nutrition for that adult should be for weight reduction. If there's an adult in the house that is not overweight, the structure should be to mitigate against overnutrition. If there's a child in the house that is undernourished, the structure should be to improve the nutritional status. If there's a child that is already overweight, overnourished, the structure for that child should be to halt the progress in the overnutrition. And we should aim for a healthy and active lifestyle. The present prevalence of gadgets and technology should be used to promote healthy living, not otherwise. For instance, there are smartwatches and apps on our mobile phones that we can use to promote more active lifestyle, increase physical activity. We should beware of using gadgets or even technology, maybe using cars, the way we ride our automobiles, or we consume the mass media to encourage a sedentary lifestyle. So we should aim for a more active lifestyle. And I ended here that each person should take responsibility to acquire the required nutritional education. There's a lot of healthy nutritional and balanced nutritional education available to us, and we should avail ourselves of this. Okay, in conclusion, I have talked about malnutrition as inadequate, excess, or imbalance in energy or nutrition consumption. I've talked about two forms. The indicators of nutrition, I talked about stunting, wasting, underweight, thinness, and micronutrient deficiency. For indicators of overnutrition, I talked about overweight and obesity, either general or abdominal obesity. And I took us through using empirical data that Nigeria is actually experiencing a double burden of malnutrition, with the rising burden of overnutrition, while undernutrition remains a big problem. I took us through some negative implications of this double burden of malnutrition on child health and survival, on the rising prevalence of non-communicable diseases, and the double impact or double negative impact on the Nigeria health systems. Some practical recommendations given include raising awareness, nutrition education, contextually appropriate intervention, and encouraging more people to be involved in nutritional research. Thank you.
Thank you very much, Dr. Adeomi. I mean, when you were recommended to be a speaker for us, I didn't realize you were going to come armed with so much data, you know, and providing your own expertise too. Thank you so much. That was a wonderful presentation.
Thank you.
There's some questions in the chat. If you can stop sharing, so just so we get a chance to see your face a little bit too. So
okay, thank you.
There's some questions in the chat, but before I take on those questions, I just want to acknowledge some of the folks here. And I know we have a lot of people here, and I appreciate all of us here. There are a few folks I want to acknowledge. We've seen several comments from His Royal Majesty Oba Adeyeba Isaac Ayeni. He's a monarch, but he's also an academic, you know, and he has asked several questions in the chat. We welcome you here, sir. Professor Segun Fatusi, who is the Vice Chancellor for the University of Medical Sciences, is here with also with some of the faculty and staff from UniMed. We have some board members here from Health for Nigeria, Dr. Fola Oluwayemi, Dr. Remi Duyili, and Dr. Ndupeju. They've always been here to support our programs. Dr. Barbara Julian, she's attended every presentation we've had, so we appreciate you. Some of my colleagues from University of Maryland, Dr. Charlotte, Dr. Ugorji, who is also here, the real Dr. Akintade, and members from Federal Government College Idoani. A lot of the alumni group are also here. Thank you very much for your presence and your support. So, Dr. Adeomi, there are actually several questions in the chat, and I want to take it from the top. I think Oba Ayeni asked us some questions earlier. So 1 second. So could a baby suffering from osteogenesis imperfecta be considered to be suffering from malnutrition?
Okay. Sorry, maybe we should run through the questions so that I'll take them together so that
okay, all right.
So
that's perfect. So that's one. There was a question about the validity of data in Nigeria. How valid the data is, even though I think towards the end you addressed that about how old the data is and how we need more data, but Nigerian statistics, how reliable are they? So if you can speak to that, how reliable are the data for Nigeria as a country that has not been able to carry out census for decades? Are we just guessing on our population? And I think Dr. Oluwaseun helped contribute to the answer in the chat earlier. There's a comment about disparity in nutritional intakes across individuals and nations and how NGOs have a big role to play. I think there's just one more question. So about, can you explain briefly how a person can be overweight and still be stunted? And so if you can start with those, Dr. Adeomi.
Okay. Now, thank you. I must appreciate the very senior members of the societies and the academia that are here. I want to appreciate every one of us and His Royal Majesty, Kabesi. Thank you. So for osteogenesis imperfecta, actually that is a genetic disorder, not primarily a nutritional disorder. We talk about it's a disorder that a child is born with. So although osteogenesis, maybe the confusion is when we talk about osteoporosis, osteo this and that, they are due to calcium deficiency. But this is a genetic disorder. For the Nigerian data, thank you for you, like you mentioned that Dr. Essence tried to respond. There are two things to this. And you would notice almost all the things that I quoted, I tried to restrict myself to national prevalences and data that had very strong and very rigorous processes behind them. Like the Nigerian Demographic and Health Survey, which is a very, not only Nigeria that is done, it has a very meticulous process and the data is highly valid. So the data there is quite valid. And the systematic review that was also done, also, like, since we're in the academia, we know that systematic reviews and meta-analysis have very strong validity generally. Other than that, the other flip side is, like I said before, There are quite a number of scattered studies that have quite some challenges, like I highlighted, and I don't want to go over it again. I would not be right to say that we don't have some data quality issues for nutrition data. I will not be right. Let me just give you one little challenge. If you are working with the nutritional data of NDHS 2018, and you want to define obesity in under 5 children, and you use greater than 2 reference variable, because greater than 2 is the one for older children. But if you erroneously use greater than 2 for the under 5 children, you will get a prevalence of 15%. If you use the appropriate greater than 3, you get a prevalence of 3%. You can see the difference. And there are studies that have been published that I've seen that actually use the wrong reference. So that there are some issues with data quality in Nigeria. I mean, I'm sorry, I'm also an academic, but we have had some challenge in that area. But notwithstanding the major data that I referenced here, the NDHS and the systematic review and meta-analysis are very credible sources of data. And I backed it up with my own personal experience. Well, I'm sorry, maybe because I'm the presenter, but I think fairly that what I've done, I think accurate. So that's why I backed it up. And you see that there was not much deviation between what I reported in my own little corner and the national prevalences. On the work that NGO needs to, or the big part that NGO needs to play. Honestly, the issue of the malnutrition problem in Nigeria, it's not just about NGO. If we'll be very, very frank with ourselves, the greatest responsibility should lie with the government. But the problem with that kind of narrative is when we begin to say it is this person, it is that person, nothing gets done. Health for Nigeria is not, even as I know it, is not one of the big NGOs, not the popular NGOs that we know. Health for Nigeria is not a government organization. In fact, they tried to get some support and did not get any, and I'm not surprised they did not. But still, at the level of at their level, they're making a lot of difference. 25,000 children have been attended to. This is what I mean by, I don't want us to just fix it on an NGO. I'm not an NGO, I'm an independent researcher. But I've realized there's a little I can contribute to, and there's a little all of us can contribute to. There is a nurse, I wish I could have time to talk about her. She's in charge of a nutrition rehabilitation clinic in Obafemi Awolowo University Teaching Hospital Complex. And she has done a lot of work, not only one person, but there's one person in charge now. Amongst children, she's just one person. She's just a worker. She's just a health worker. She's not an organization. So the issue about malnutrition in Nigeria has left the stage where we say it is this person that should do. I agree. The NGOs have a lot to do, but all of us can do a lot at our different levels. For overweight and stunted, in fact, the high stunting rates in Nigeria is what is actually driving the epidemic, the obesity epidemic. Because stunting is such that there is a limit, the height is not appropriate for the age. When a person's height is not appropriate for the age, you know the problem with that person is that for some time the person had some chronic malnutrition. But things happen. I was joking with a friend of mine who grew up in a very humble background. He's a medical doctor today and a very successful one. Of course, his height is not, well, I don't want to say he's stunted. Well, let me just say he was obviously stunted as a child. But now he's better. He travels in and out of the country. He eats better. And so now he has added a weight that the height cannot support. So he's on the obese side. And I've had to warn him a couple of times. So this is the issue where we have children where they start off and things are very rough, or some people just struggle through childcare and they don't know the right feeding practices, and the children are undernourished as children. Then, as they grow older, the status of the family improves and the feeding conditions improve and the child begins to eat more. But what is stunted is stunted. You know, the problem with stunting is that it doesn't recover much or even at all. Some people say is irreversible. Some say it recovers very slowly. So when there is a background of stunting and there is subsequent eating of, more of the energy dense and nutrients, then it will be understandable why obesity can now build up on an existing structure of stunting. I think these were the questions you asked.
Yes, those were the questions I asked, and now I'll ask a final question. Thank you, sir, for the enlightening discussion. Can we address the current nutritional issues as discussed, bearing in mind the current economic situation in Nigeria, where the supposed cheap available food items are now extremely expensive? The affordable Tom Brown is now very expensive, and mothers at my center are now unable to buy it. So essentially, what you just said, but talking about proper nutrition and aligning that to our economic situation in Nigeria.
Okay. This is a very big issue now because of the economic challenge. And I quite agree that the economic situation has worsened or has the potential to worsen the situation of malnutrition in Nigeria. But honestly, as a researcher and with my little experience in the field, sometimes the economic situation is not as much as is often portrayed. Because, like I gave the example of when I was serving in Sokoto, while many people, when they think about balanced diet for the children, they think that expensive means that is balanced or is adequate. Actually, we use the word adequate now because the idea is not to balance food. So that you cannot afford to buy an infant formula of 20,000 that is now 40,000 does not mean that I agree some ingredients are more expensive. But like, for instance, let me give one thing that for the children that we see at our nutrition clinic, a number of them are not very, wealthy or so rich. There are some practices, some home practices, some additional things that may be possible within the context of many of them, because many of them are from rural communities. One of them is they could buy some chickens in their compounds. The chickens could lay eggs, which they could use. They could raise them for next to nothing. They could raise vegetable gardens. They could have some other little ways to address some of these things. While I agree that the issue of the economic issue is complicating the nutrition, but I still think that we need to explore more of the cheaper alternatives and opportunities. A colleague of mine, I don't know whether he's here now, for his PhD is working on cheap sources of protein within the communities. And he's coming out with very interesting findings that, when we were young, we used to take termites. I don't know. That would be strange to some people from the Western culture. But yeah, and so he's trying to go back to review some of those things and review their nutrient contents and how applicable they may be to help in the situations. So the economic situation is bad, but the message is that we should not just throw our hands up in the air that there's nothing I can do, and we just have to surrender to the problem. There is a little we can do within what is available. That's just what I'm saying. Thank you.
Once again, Dr. Adeomi, thank you very, very much for your presentation. Thank you for taking the time to respond to all our questions. We truly appreciate your time and expertise. You are also giving back. Most people would have had to pay to listen to this lecture, and you've done this for us for free. That's part of your contribution to the greater good in Nigeria. So thank you so much. And once again, thank you to everyone that joined us today. I mean, I hope you were just as enriched as I was. I took so many notes. I took so many notes. You know, I love data. I love data-driven conversations too. So thank you very, very much for this. And thank you everyone for joining us. And until the next time, please, there was a message in the chat to provide some feedback. We would love to get feedback. This was also recorded. The video will be on our website if you want to go back and, you know, get some additional information. Dr. Adeomi presented, you know, it'll be available to you. So once again, thank you so much for your time and enjoy the rest of your day. Thank you.
Thank you.
Thank you, sir.